Well, you have to believe it first, and you don't. I can send an Uber over, throw them in the back of the car, and get them somewhere. It's just interesting. Best you disrupt yourself than let someone disrupt you, because at least you get to control the disruption. 5.5 million patient encounters.
5.5 million. Ooh, I had that wrong.
Yeah,
5.5
our
million.
database is now a little over 80 million records. We have line of sight to getting to 100 million patient records.
Literally, the patients now got control where they used to not. It used to be. That is all going to go away here in the next 12 to 18 months. We are going to see a radical transfer, and I don't think the healthcare provider community is ready for it. Hello, and welcome to another episode of the Leadership Lab with Asbel Montes. We've kind of been on this healthcare kick, and so number one is if you haven't subscribed, hit that subscribe button below and share this with your friends. The more we get that out there, the more it hits those great algorithms that we're talking about. But today in studio, and I'm in a new studio set, but I have Nick Loporcaro here with us, the Chairman and CEO for Global Medical Response. Many that are watching probably recognize the name, but you probably have recognized Global Medical Response being the largest ambulance service here in the United States. Yeah. And I am ecstatic to be, number one, here in your city, in Dallas, and in studio live with you. So, Nick, glad you're here. Thank you for joining the podcast.
Glad to be here. Thank you.
So let's talk a little bit about your journey, because you started, you've been in healthcare for a while, but you started with GMR back in 2023. Give us a little bit of your history for those that may not know. Of course, a lot of us chat things now, and it can give you a lot of stuff. Sometimes it's wrong. Yeah. I actually did a chat on you, and I'm like, that's not right what it's saying, because it had gotten it wrong. So give us just a little bit of the Nick story.
Real quick. So I grew up in Montreal, Canada. So if you pick up a bit of the accent, you'll know it's from there. An Italian immigrant family. So I got a bit of Italian, French, and my broken English. I'm a mechanical engineer by training. And so my wife, now we've been together 34 years. I said I've sort of come full circle. I used to design and build a lot of utility equipment. But I've been pretty privileged for the last 23 years now. I've been in healthcare, stumbled into healthcare due to my dad's health many years ago. He had succumbed to Alzheimer's. We were living in Virginia, decided to go back home, and I started working at McKesson in Canada. And we had a pharmacy automation business. I knew automation. I was an engineer, but I didn't know anything about healthcare at the time. So cut my teeth on the pharmacy side, ended up being the proverbial CEO of the Canadian business, and then in 2014 was asked to come down to Houston to lead what was called our specialty business. And it was primarily oncology at first, the U.S. Oncology Network, and then we started expanding it. I'm going to say we built ecosystems around anything that had ology on the back end. I took over the pharma leadership, which brought us to Dallas. And right in the middle of that, I got approached about running, at the time, a small nascent business that had just started growing. It was in-home medical care, not home health care, but truly bringing physicians, nurse practitioners into homes, taking care of and providing medical care to very frail, geriatric patients that were highly chronic. And it was value-based, so it was all at risk. And so I learned that. We ultimately sold that business to Optum Healthcare. I stayed for a while, and I somewhat say this in jest. I made a futile attempt at semi-retirement, and again had the privilege of getting a lot of healthcare boards, and then KKR approached me with GMR. And this is a very public story. Many people have heard it. I talk about my why. So I sat down with KKR at the JP Morgan Healthcare Conference, and they were telling me about this business, Global Medical Response. And they kept referring to it as medical transportation. And I'm not the smartest guy in the world. I get that. I know, kind of looked at them and said, I know you have a lot of ambulances and a lot of aircraft. I said, but why do you keep referring to this as transportation? And I was getting annoyed, like visibly annoyed about this. And I said, I think you're doing a disservice to your caregivers. You have like 24,000 clinicians. I'm sure they don't like to be referred to as drivers or transporters. So true story, I got so upset about it, I said I'm going to join the company to prove it's a healthcare company. And that's my why. That's that's what's driven me around GMR and EMS overall, and sort of the passion around this industry.
I love that perspective that you just gave here, but just as a side funny note, I can tell you're an Italian. You like to talk with your hands.
Yes. You know how you mute an Italian, right? You tie their hands behind their back.
I love it because I talk with my hands as well. And I'm consciously, I'm like, oh, we got.
I'm doing my best to hold them right here.
I love it. You don't have to worry about it. I love it. But that's an interesting story coming in from 2020. Like you've only been with us in the industry for 3 or 4 years. Some of us have been in this I've been in it 29 years. You've got counterparts that have been in it much longer than I have. But to see and understand and make that correlation, because that is something that I know the industry has been trying to pivot on. We are more than just transportation, and we're struggling with that, and we're going to get into some questions. Mm-hmm. So because I literally want to understand your perspective, how do we change that narrative? What do we do? Because that is what we do. We are caregivers. We give care. Sometimes we kind of, I was about to say we suck at it, but I am going to say we don't tell our story very well.
We don't, Asbel, and I think as I looked at some of the things you want to cover, and I think we'll touch upon it in our going public experience. We conducted over 120 meetings, educational meetings with healthcare analysts and investors, and I'm sitting in front of very educated, smart healthcare analysts. And they knew nothing about EMS. And I learned a long time ago, when your audience doesn't know, it's not their fault. We have not crafted our story well. We've hemmed and hawed about it a lot. We've banged the table. We've put the head out. But I can tell you it is changing, though. I'm very optimistic. I spent a lot of time on the Hill, a lot of time with payers. This experience, people are getting it.
Yeah. So let's talk about that. So let's talk about the one thing I want to kind of talk about, and from you coming in and looking at this from a 50,000, 30,000 foot view, I would really like to understand from your standpoint, because you're now the only publicly traded company now in the United States. That just happened recently. We'll talk a little bit about that. But tell me from where you sit, like from your perspective. I don't care about anybody else's perspective. From your perspective, what does the ambulance industry actually look like from the inside that you think the public doesn't understand? This story where you're talking to individuals. Give me your perspective on that.
So I'll give you a couple of perspectives, and it'll come with a warning. I'm a storyteller, so I've got lots of stories. And I'll start with one of the stories. So I was invited, we have our revenue cycle up in West Plains, Missouri. And I was invited out there for our 25th anniversary, and the first CEO of Medtrans was there. So I got up, they asked me to speak, and I give my soapbox about my why and everything. And he walked up to me after my speech, and he literally was teary-eyed. He was, and he said, "Thank you so much for recognizing what you did." And he says, "I have to share a story with you." He says, "When we started, the business, the Airvac business," he goes, "we started it to get to you, not to get you somewhere else. It was to get to you in your time of need. And yet the whole moniker and framing of EMS is get you to a hospital versus get to you in your time of need." One of the phrases we used a lot in educating the market was, we're the tip of the spear. We're the front of the front line. And our ability to truly navigate patients through the system to get them to the right site of care, the right modality of care, making sure you're getting the right form, and more often than not, giving that care. And the irony for me is we live it, we know it, and yet, and I'm going to name some names who who've been on your show and you've interfaced with. So when I came into the organization, I was with Dr. Rock, and I consider Dr. Rock the poster child for EMS. And he's
an amazing guy. He's an amazing guy.
I rib him a lot endearingly. I would follow anything he would advise with respect to EMS. So, we had just met, and he heard my sort of soapbox about and he looks at me all excited, and he's giving me license to share this story. He looks at me and he goes, "So Nick, how are we going to get people to believe this?" And I looked at him square in the eyes, and I did something pretty bold for a first meeting. I said, "Well, you have to believe it first, and you don't." I'm talking to the individual I consider the poster child for EMS, and he knew exactly what my point was. Shortly thereafter, I was in the field, and it was the first time I heard the phrase, "You call, we haul, that's all." I believe Dr. Moy on yours, And Asbel, I was heartbroken. I don't easily lose the ability to say something, but I had this pause. And in my gut, I said, if our people really believe that, if they believe that others believe that's what they are, boy, we're in trouble. It literally bothered me, just like when it bothered me when you talk about transport. And I think about what our folks do in the field every day. I think another one of your podcasts, you had Larry on from America, when he said, I'm in a ditch doing that's not transporting. And it's not easy. And these people, this is a mission for these people. So a long-winded way to get back to your question, we know it, we live it, and yet the rest of the world just knows I dial 911, ambulance shows up, and then I get this big bill. And I don't understand it. People don't understand. You want me to respond in that time frame? Well, we need to be ready. We need to be equipped. You look at what's in, I always say, again, I'm not the smartest guy in the world. I know we have a lot of assets, but they're mobile ICUs.
Okay. Donnie Woodyard said this clear on one of my podcasts, and it resonated with me because it's true, is the patient has an interaction with us at the time of call. Their next interaction with us is when they get a bill. Mm-hmm. And there's almost nothing in between. But yet in other healthcare provider specialties, there's kind of a constant, there's a lot more interaction that's happening. And I've heard that, you call, we haul, that's all. And many times the voices at the table, we have the wrong voices at the table. And that's kind of why I'm on this whole data doctors leadership kick right now, Nick, is the doctors have got to lead this. Mm-hmm. There's a lot of smart minds in our industry. There's a lot of things that we've been asking for that we have not, has not happened. There's playbooks that we are playing today that are playbooks that we executed 15 years ago. Mm-hmm. There are some things, and I just laugh facetiously at this thinking, we're talking about this. Let me go look from my files from 2012, 2013, it's literally the same exact talking points. And so I'm optimistic with where you are. I think we're seeing that doctors are taking back the narrative, not just in EMS, but in healthcare in general. It's pretty amazing to watch. I just did a podcast, and it's going to be live by the time this one shows, with Scott Becker from Becker's Health Media. Mm-hmm. And we had a phenomenal conversation really about going back to the basics of supply and demand. And when he was talking, of course, I wasn't talking EMS with him. It was just in the general healthcare context. But that is where we are. We've got to get back to the basic premise of what this is. Healthcare is a business, as Dr. Cozy indicated from the doctor's perspective, but doctors didn't understand they're not even trained in healthcare economics and understanding it to be a business, but they're taking that back, which I love what I'm seeing generated. So let's kind of talk about that, because you shifting, I'm going to go off script here just a little bit, but we're going to switch around. You guys going public. I think there was a thought that the initial offering is going to be larger than what it was, came back with something different. I'd really like to understand your perspective. Is that, because generally speaking, I don't know if I really always want to say the way Wall Street views things, but you kind of see a common thread sometimes about the importance of what EMS actually does. There is a confusion among legislators, regulators, the general public on what EMS is outside of what the movies make it seem to be like, which is not the reality of what's happening in EMS. Talk to me a little bit about that and where your stance is on what played out over the last 60 to 90 days.
So we're going to unpack a lot of things here, and I doubt either one of us are going to stay on script.
I love it.
I'm about as bad as you are at staying on script. But so let me hit a couple of perspectives first, just to sort of couch where the crux of your question is. And I don't profess to be a stock market pundit. I'm a Squawk Box junkie. I love watching CNBC every morning, especially when I travel. And I've learned one thing from it. You can get equally qualified, smart people, have two very different opinions. And at the end of the day, what you realize is the stock market's very irrational. Especially over the last 2 years. So there's that. Yeah. And then there's the SpaceXs and the AIs. And the reason I bring that up is what you've seen lately in the stock market is all this money that these funds have limited, funds. So they're collecting their marbles so they can go chase these other things. So you have those two dynamics externally. Now, to the crux of your question, and I alluded to it a little bit earlier, when we went through this process in educating the markets and the analysts, it's a difficult business to understand. And then you look at GMR at scale, and what we've been adamant, and a lot of people try to figure out, like, what's your ground business? Like, what's your air business? Like, we keep saying we have an EMS business. We're actually trying to get the industry to talk about patient encounters. Get rid of transports out of the narrative. And yes, we have this huge logistics infrastructure that supports what we do. But at the end of the day, we're delivering clinical care. And so when you look at it, and they said, a lot of people would say, well, you're an N of one, scarcity value, that's pretty cool. But it's difficult to get your head around all of this. So we started at a higher level in the mid-range. And then what became sobering was that sort of misunderstanding dragged us down a little bit. And in full disclosure, I mean, I don't think it's, what we're being valued at from a multiple perspective is the wrong one. So put it out there. It is what it is. What drove me to say we still needed to do this, and no pun intended, was our ability to continue to make the message public and to continue to educate. So what we know now as a publicly traded company is we have to deliver the results. That's, you just got to do it. But at the same time, we can continue to demonstrate. And where we've continued to demonstrate is we've had phenomenal success, and we get tons of stories with payers now recognizing in these communities where, and I think Dr. Troutman covered this with you when we talked about our Nurse Nav, where we put Nurse Nav into a community and the payers actually recognize what we're delivering. We've been able to negotiate better rates. And I know you and I have debated the treatment in place or treat no transport. Honestly, I don't care what the label is, but when we take care of the patient, getting reimbursed, or if we get you to an alternate site of care, we get recognized. And then that loop, that feedback loop, we're working with Dr. Beck and ESO, and I think we're piped into like 1,500 hospitals, where now we can take our outcomes data, and not only the outcomes data, while we're tied to those physicians in that communication. And I think those are the steps that win us that credibility. Just slamming our hands, on the table saying, well, this is what we do. Okay, now we can show it. And that's the ability with technology and data today is we can show those outcomes. And it's not anecdotal anymore. Like, look, everybody knows that if Mima doesn't need to go to the hospital, first of all, it's the worst place for her to be if she doesn't need to be there. Those are like 5-figure bills. So you may have saved the $500 and not paying me for a dry run, but someone's going to pay the hospital. And the system's going to absorb that.
So let me ask you this, because you brought up the data. I love the data conversations right now. And I just aired this week Dr. McCoy, who's the former president of Blue Cross Blue Shield. He also now runs of Texas. He also runs now an AI company. He's really had a very in-depth conversation about AI and how that's going to be in the payer space to the provider space. How is GMR using that? Now that we have all this data, you're connected. You're obviously doing something with Dr. Beck now. You are a repository of over 2 million, 3 million patient encounters you're doing a year. How have you guys as your organization adopted AI into this process, and how are you going to be using it? Can you talk about any of that?
Yeah, a ton of them actually. And so 5.5 million patient encounters.
5.5 million. Ooh, I had that wrong.
Yeah,
5.5
our
million.
Database is now a little over 80 million records. We have line of sight to getting to 100 million patient records.
Okay.
So you think about all of that, right? Now, how do you use it? So I've challenged the organization on AI. One, we have an AI governance committee just to make sure, because we are healthcare, and I'll start with the punchline and what the goal on how we best leverage AI. My ultimate goal for the organization is that we free up our caregivers' time so that we optimize their hands-on patients. I don't want them being bogged down with charting and coding and all that decision support, which I believe I saw in one of your podcasts as well, is like, how do you guide them to make them efficient? Not make the decision, guide. And so one of the coolest that we did is, we have over 200 medical directors. And I remember talking with Dr. Rock, and I said, so how many different clinical protocols do we have? And guess what? Everybody's got. And I said, I'm willing to bet you that what's on page 5 on a PDF file, paragraph 2, shows up on a Word file on page 2, paragraph 5, and they're the same. And I've been through this before in my past experience. And so, and I always quote Pareto. I said, I bet you it's like an 80-20. Well, Dr. Rock came back and he said, it's more like 90-10. And we achieved that by sort of unleashing an AI bot on all these kind of, it ingested all of them and started finding all these correlations. And there was a couple of goals to that. One, to be able to bring back to America and go, look, this is you. This is not us. We didn't make this up. This is what, and when you can get that alignment, start now attaching that alignment to the data you collect, the power of iterating on that, and that's where AI really does help when you start thinking about the clinical quality metrics. Now, on the flip side, revenue cycle, same thing up front. Like, I can take a picture of a driver's license now, and boy, I can pull a ton of information. Going back to how do I optimize our caregivers' teams' time with patient, and with either the physicians in communicating as they're doing all of that. So we've got a ton of different AI initiatives going on within the organization. Areas that are also sensitive on our nurse navigation as we look at, some of those algorithms. And I think Dr. Troutman had explained this. Ultimately, our nurses have the call. If they're not feeling comfortable about something, they want to question it, they go back to the medical directors. But we've woven AI into the organization. Probably early innings on some of the things we're doing, but have embraced it as an organization.
That's good, because I think that's kind of where healthcare in general is just, they've been slow to adoption. But now I remember attending a conference last year with the physicians, nothing with EMS, but the physicians, and some of them were like, it's a no because of PHI. This last time I was just in, I think it was Charleston, that I was out with the emergency physicians, and the whole narrative had changed. Mm-hmm. Everybody was adopting it. The ambient AI concept of giving clinicians back more of their time to spend, that's been very interesting. Now the notice and consent provisions. Are you guys doing anything around the ambient AI process yet, or are you guys just still dipping your toes into that?
Dipping our toes only because of the sensitivity. And honestly and ironically, it has less to do with the PHI, because I think we can protect that, and more respecting the individuals in the ambulance as well. And how we do, because we do use AI on some of our apparatus for safety reasons as well. Sure. Are you nodding off? Are you in those alerts? So we've integrated, and that's sort of the dipping of the toes, is just being careful. But the adoption's been pretty good, I think. So we have a team. Tom Maxey and our team leads what they call the nerd squad. They get Rubik's Cube and looking at our EPCRs and how we made it easier, as opposed to traditionally everybody would add a few more check boxes. This is making the load lighter while capturing even more information.
Looking at budget cuts? Running out of cash? Look no further than the third payer. You already know the two payers on every claim, the patient and the insurer. But in accident cases, there's a third payer you never billed, and they've been off the hook this whole time. Black Inc.'s TPL Discovery surfaces the third-party liability, so the right payer finally pays. On average, we hit on greater than 50% of the accounts we run. Revenue you already earned, recovered. We'll prove it first. One complimentary run, no cost. There's a third payer. Let us help find them. DiscoverBlackInc.com.
Excellent. All right, so we're going to switch the subject and get into something, because my background generally is the healthcare finance management side of things. And so there's many initiatives that the ambulance industry, so if people are listening to this that's not interested in the ground ambulance industry, then you can kind of move on. But we're going to kind of get into the EMS side, the patient encounter, and kind of start talking through from your lens. And I'm interviewing you. You're the CEO chairman of Global Medical Response. I'm open. I listen to all ideas. I don't have to agree with everybody. I think it's very important for us to get, because we can get to consensus through things. But I know there's different perspectives of how to take the data that we're starting to see come out. First time ever, the industry has had a comprehensive data source. And I was having this conversation with a colleague last week, is we have to be realistic as an industry to understand that we've had 3 different governing reports that have come out over the last 20 years. We've had a MedPAC report, we've had a GAO report, and now we've had this last MedPAC report, and they simultaneously kind of paint a similar picture. Okay, different details, but a similar underlying picture. I'm doing a webinar with a healthcare economist on July the 8th, I think that's my birthday, to discuss from a healthcare economist viewpoint what this means, and she actually crafted some of the legislation, ways and means that actually helped with the process of the data collection period. So just to kind of understand that, I think it's important for us to have a realistic conversation about what we should do with this. How does this data help us? What should we be paying attention to? But from your perspective, because I know at an organization your size, you guys are going to have been looking at this. It would be rightfully so. Tell me what you think the industry needs to be doing relative to what this data is telling and how we should be looking at this for reforming our system, doing something different, infusing it with more cash, doing something, because we keep talking about we're not being paid enough by some of the federal payers. How do we look and offset that?
So a couple of perspectives. I'm gonna start with I had the opportunity to meet with Dr. Oz. It was the evening of the State of the Union, and I remember that because they were shutting down the city around us. Well, we were about to meet. I got a half hour with him, and I remember saying to him, I said, Dr. Oz, I said, first off, thank you. We had 4 points we wanted to cover with him. I had given him a briefing paper. I said, if we never even touch the 4 points, the one message at the end of our half hour that I hope to achieve is that you recognize that EMS is an integral part of healthcare delivery. Never use the word transport. At the end of our conversation, he says, I'm aware that we have not leveraged EMS well enough in healthcare, in delivering care. And I went, sort of dropped the mic, good, my job is done. And we did get to touch the other points. One of those points was reimbursing us, not so much about extra dollars, reimbursing us and recognizing what it is we actually deliver. And I think it was Dr. Moy on your podcast, which we've got to get from, under the transport benefit to a Part B type of construct. Because what's interesting is when you look at what we can deliver to Part B, we don't even move the needle from a cost perspective. Yet the value we can deliver is enormous when you think about all these models. So yes, there's a transport component, and all of the logistics of what we do should be factored in. And everybody says, we haven't relooked at costs in 25 years. And we always talk about, wages and those other, what we lose sight of is just the regulations alone. Look at what we equip these assets with. Look at the equipment, look at the skill sets, look at the regulatory alignment, all the certifications, the credentialing. So you've got all of that hasn't caught up. But when you look at all of that, what does it mean? Like we've made all these investments, and yet we still look at it as transporting someone to the hospital. So why I don't need that. I can send an Uber over, throw them in the back of the car, and get them somewhere. It's just interesting. Side note, I won't name the community, but there's a city councilor recently said, "Oh, if I'm having a heart attack, my neighbor can take me to the hospital." So, okay, you know what the downstream impacts are, relative to having professionals, clinicians, take care of you. So when I look at all of this, I think step one is we need the right framing. And going back to your comment earlier, but we're using the same playbook, all we're doing is bringing more costs and say, well, you have to pay us more. Versus going, this is what we really do. This is the value we provide. Let's start there. And if you recognize us under healthcare and reimburse me from there, and then we can isolate the transport components or the sort of mechanical components of that, then great. Now I think we start getting to a solution, right? Versus just going back and doing a cost analysis of this is what it costs us. And yet we've not looked at the other side of that equation.
So I think what happens is, and I'm just, as you're sitting here talking and you're bringing up some really good points because there's such a great dialogue that's happening. But at our user summit that we had in Laguna Beach, I had Dr. Graybear, Lisa Graybear, actually kind of talked about the different systems that had. Her acumen is in the hospital-based system and the PPS program, and really having a dialogue saying if you really want to kind of keep the same as norm, stay in the same system that you're in right now, which is the point that is the transport system, basically, because that's how we're getting paid. You got to transport the patient somewhere. Or if we really want to move into what you're talking about, we might want to rethink a very disruptive model, like around a PPS model. Mm-hmm. And that's really hard for an industry to grapple, not just our industry, but anybody that's been in a more fee-for-service environment. Physicians are struggling with this, to move into more of a PPS because it looks different. it transitions differently. It's more of kind of a long-term. And in her mind, long-term is 3 to 5 years. And I think when people think long-term, they think 7 to 10 years, 10 to 15 years. But we've done this before back in the 90s, like late 90s, when we did the first part in the negotiated rulemaking. There was a transition of 5 years. So we're used to doing it, but some people around now may not have been aware of that. Where are you? Is that kind of what you're talking about here, that we may need to look at a PPS system or something like that? Can you expound further?
So there are examples currently that we have that can either, whether it's PPS or the PMPM models or value-based or, and again, at the risk of repeating some of this that Dr. Troutman covered with you guys. So we have some communities where the county is subsidizing putting in nurse nav. So when you think about that, PMPM type model. What's interesting, though, and I alluded to this earlier, is the payers in the community, and one in particular that we have a very good relationship, recognize that if we have nurse nav in the community, it's a better system, so they're willing to incentivize us. Now, that incentive I get today for that treatment is a fraction of what I'm actually saving the system, and I think that's where the opportunity is. And I care less about the wrapper you put around it. It's more that recognition. We have other communities, and again, I know in the podcast he alluded to this, is that we have an arrangement with the EMS organization there where we're providing a service and this is embedded. And the irony of it is doing nurse nav, even in our own markets, is better for ourselves. We operate better. So we're starting to show some of that evidence. We are getting the recognition, and we are getting different forms of reimbursement today. And that's sort of, I like to use the flywheel. I'm an engineer by training. It's sort of like the more of that we can do, and I've heard terms on your podcast like collaboration, alignment, like the more of that we can do and bring up the discipline in the industry, the better traction we're going to get. But if we fall back to the old playbook, we're going to get disintermediated. The term I often use is best you disrupt yourself than let someone disrupt you, because at least you get to control the disruption.
It was a very interesting call, because this is what I talked about with Scott Becker on the call. The way I met him for the first time, and I didn't know him at all, but I attended a conference of his in Chicago, and he brought in the financial companies, the banks, and talked about the disruption that happened to them through Dodd-Frank. And it was almost like a lesson, and he brought in the top 5 CEOs from the healthcare systems and had a discussion with them talking about what did the lessons learned from the financial industry with Dodd-Frank that became so disruptive, and it caused a disruption in their market. And if they would have worked together, they could have planned their own disruption, but the government started, and the government never does anything right. And it's almost like fast forward to now, we've had the No Surprises Act. We've had the One Big Beautiful Bill that's happening here to put crunch on. And it's almost like the healthcare industry in general is not working together. So I get your point about saying, let's do collaboration. I want to kind of spin off that, and this is not in our notes to talk about, but you just prompted something, so I want to have a conversation about it. When I was talking to Larry Richardson, who's the CEO of a company called Ameripro, they're private equity backed by a company called Whistler Capital. And we kind of got into, because there's sometimes misnomers in healthcare just in general, that private equity's bad or Wall Street's bad. There are bad players, bad actors in every industry, but there's also good players. And that's kind of the point, kind of understanding and saying the innovation that we have here in the United States of America, because of that, you got to have capital to reinvest and to do some things, and that was kind of the point. And he made a standpoint of saying some are in the business of just real estate. I'm paraphrasing what he said. And some others, they really are trying to build. They are really trying to do care thing, whatever. Your experience now that you've worked into the public side of it and the collaboration of it. I've been in this industry for 29 years. There is a distrust amongst everybody. I don't care. We have all these different models, from fire-based models to third service-only models to nonprofit models to for-profit models, private for-profit models, public for-profit models, private equity-backed models. Let's talk about collaboration. Sounds fun. Consensus sounds fun. It's a component. I love it. It's sexy words right now that we're really talking about. But there are some of us that really understand. I can sit and disagree with, but I can get to probably 90% of an agreement with you on something, and I'm not going to allow the 10% to keep me from the 90% agreement. I can put that to the side. Unfortunately, we do have some people that they just focus on the 10%. Yep. What are you doing And what is your plan and your initiative and your thought process you're new into this industry, of bringing that consensus together? Explain to me what you're trying to do.
So a couple of things. I saw the episode with Larry and fully agreed with a lot of what he's done. I've had a lot of exposure to private equity through, I've chaired a lot of companies. And I can tell you, I'm going to plug KKR. They've been excellent partners. And if you followed the public raise, they actually put in an additional private placement. That's how much conviction they have in where we're going as an organization. I'm going to start with, so I came up with this model 20 years ago, and my corp dev guy decided to memorialize it. It's a very simple, I joke about it, it's your healthcare economics 101 course. You have the patient, the payer, and the shareholder. And I say patients need everything you can give them. Payers want to pay as little, if anything, and shareholders want competitive returns. And I always remind people, shareholder, by the way, could be the tax base, could be your 401k, could be your pension plan. It's not always private equity or public. Because if you don't give them competitive returns, they don't put capital into the business. And then you can't give patients what they need at a price point payers are willing to pay. There's your Healthcare Economics 101 course. I've never shied away from telling that to a physician, to a caregiver. It's just the reality. You've said it on this podcast many times. Healthcare is business in this country. I was raised in Canada, very different model, but it's not that different. So when you think of it, you take that construct and you buy into that. You start to realize, first and foremost, let's focus on the patient, and not naively so. You got to deliver the right care. Payers can only sustain so much, and then you've got to do it in a way so that you can continue to get investment. From a private equity perspective, you said something, and I don't mean to be harsh about this. I think it's just a matter of fact. Governments aren't wired to run stuff. They regulate, they reimburse. And it's probably all they want to do. But in the void of someone taking control, well, guess what? They're going to step in. And they're probably going to do it wrong because they don't know it as well as you do. So you step in, you make the right investments, you go down that path. The public path for us was to raise that capital so we could delever, and then again continue to invest. From a collaboration perspective, and I'm really proud of our organization, I asked our team, I said, look, we're the largest in the industry, so we bear a responsibility to raise the tide for everybody, for EMS. Now, competitive-wise, I want to be the best boat in the water. Well, I'm not going to hide that. But I got to raise the tide first, and I've got to get everybody there. So we created an alliance last year focused just on emergent care. And I was very open with the associations. I'm not trying to build another association. They have their place. This was really around all of the rescue act we put together, thinking like continuing to motivate that, view us and look at us for the value we deliver, not just the costing models. So we funded that initially, got a group together and brought a consultant, an industry leader that had a lot of credibility, and we sort of stood back. We participate, and support AAA and AIMS and everybody else. We do a ton of work. We have a government affairs office full time in DC, and I've always offered to our partners in the industry that if you want to lean on us, we have open forums. On the clinical side, Dr. Rock's team, Geneva, Dr. Troutman, they're out there very openly sharing what we do. So from that perspective, I believe we're doing it. I'm somewhat biased, obvious, that we're demonstrating that leadership. When the VA stuff came on, again, we were asked to go and meet with them, and our position was we want to educate you. We never talked about the dollars. Again, to put sort of that light on what does this industry do. Now, as a company, I said this earlier, we're trying to get to patient encounters. I want to take transport out of the narrative because I touch 5.5 million patients, and we touch them in very many different forms. They don't always result in a transport. So I think the more we can do that and move the ball. Now, at the same time, I'm not naive enough to believe that people look at us as the biggest and we're doing it for our own best interest. Ultimately, we want to succeed. But I've also learned in my many years in business that if I just go down a path and stay focused just on our success, then the industry crumbles. And it's just that much more difficult. So I'm hoping people are seeing that. I know we've had conversations, and we're grateful for your insights as an organization. And I think we just need to continue to do more of that. And yes, you're going to get the 10%. You're going to get the disagreements. But if we let that, if we can get aligned even on the 80%, or like that's pretty good.
And I agree with you on that. And it kind of I'm thinking of an analogy as you're talking, that in the hospital industry, they've got, the hospitals, and then the big hospitals get together through the Metro Council. And then we have the rural side of it. And that's kind of been a discussion that has been discussed because there's so many different models, Nick, out there. And one is the rural side of things that people are paying attention to. And rightly so now because of the One Big Beautiful Bill, the Rural Health Transformation Program that's happening. And in my opinion, I've been very vocal about this. I think we should be looking at things in two different buckets. One bucket is that it's very rural-centric bucket and how we're going to fund to make that a sustainable model where patients are provided with the access that they need. I don't care if it's what kind of encounter it's through. I agree with you on the encounter concept. But in underserved markets, which could be very large urban markets, which is where a lot of it is, that model could look something different.
Yep.
And I think that's the discussion that needs to be had at the very high level, even at your level, versus I understand the value proposition that we're talking about, like where's value? Everybody's trying to do the value proposition, not just EMS. Home health is trying to do it. DME is trying to do it. EMS is about to come under scrutiny with some of the fraud, waste, and abuse initiatives that deal with more on the non-emergency side of it, which really is probably not really the non-emergency ambulance. It's more the medical transportation side on the Medicaid piece of it. But unfortunately, the average consumer doesn't know that. And so telling the story is important. I'm a storyteller. And sometimes we tell the story the way we want to hear it, and we got to tell the story through the lens of someone else. And that's really hard for us in the EMS industry because people see us as heroes. And I think that's probably the most important thing. As we're kind of winding up, I've got a few more questions that I want to talk to you about. And I want to keep it on the funding and reimagining funding, because I get the value moving to patient encounters. Some of the examples that you're giving are very centric to a very localized regional approach. And it's interesting that you're saying that, because when I talk to a lot of people, they start saying the same thing. And you've always heard, when you see one EMS system, you see one EMS system. I don't buy that argument.
Nor do I.
I've been around, seen it. No. Y'all all operate very similar. You might have a different idea, but you still have clinicians on the track. It's still a truck that goes out there. Some of you did, it's all very similar in the model.
I got to tell you, I have to share this. This is another one with Dr. Rock at one point, and just to drive the point where we're doing the clinical protocols. I said, so you're telling me the human anatomy in New York is different than the human anatomy in Utah? And they stop, right? And they look at me. And I know that there's a local component. This is where I quote Pareto. It's the 80-20. I think, one of the things, like you look at an organization like ours and you say, can you still be local? Yeah, we're bringing the best practices. We're bringing the investments, how we can, and then we're allowing those teams locally to adapt to those markets. But the bulk of what we do is the same. And we lose sight of that. And throughout my career and my life, the number of times I've heard, well, we're different, or it's different. Boy, that's just fodder for me to walk right into and go, okay, let's talk about that. There are differences, and you need to respect them. But it's the 20% or the 10%. It's not the 80 or 90.
And I know that when we're talking to, and you probably heard that when you're talking to the healthcare economist or whatever, and they bring it out, and they're like, Asbel, I agree with him. I get it. The problem is some people in the industry, in the healthcare industry, EMS is part of it, that just says no. It's very localized, and from the healthcare economist perspective, when they're looking at no, this is anecdotal stuff that we're talking about. We can take these different data elements, then we can go through here and we can create a regression on it to get to what we need done. And then we're countering with an argument because we don't understand the healthcare economics that it is. We've got people out there that think they do, that do not. And the individuals that regulators are listening to, as you know, is the healthcare economist. And so we have the wrong people at the table because we've got to guide them. And that is probably the original reason why I brought up the point that says, being the largest fish, which you guys are, sometimes you have to guide and let somebody else be at the point. You understand that concept. The point is getting everybody to that concept, even within your organization, because it's so large. And so how do we do that, Nick? And that is my whole standpoint, that the reason why I'm doing podcasts now versus doing some of the other stuff that I've done is I will tell you almost everyone that I talk to that's outside of a different function actually agrees with me. And this is what I learned when Donald Trump, President Trump now, won 47 again, is he understood the power of getting to the people in the podcast. Now, the people may not always be right, but to get the dialogue out there so we could have further dialogue. Mm-hmm. And that is what you're seeing now. And so part of his telling the story is to say, wait a minute, the doctors, I started talking to the doctor, wait a minute, you're the white coats in the room. If I bring you guys into any room, I could say the same exact thing that you're saying. They're going to listen to you before they listen to me. So I had an aha moment. You're not meant to be at the table. Mm-hmm. There are some areas you just guide, you provide the information. You know where your area of expertise, and we sit at the table and do that. So I want to understand from your standpoint, because you're doing something that makes sense to me. Some things you're doing that's not making sense to me, I'm pretty vocal about that too, but we're not going to talk about that. That's your trajectories as your whatever. But bring in the awareness of the value of who we are, but it has to come through the right people. Let's talk timeline. 2023, you came in. There's a lot of discussion happening. And if we don't navigate this ball correctly, our very best intention could explode. Mm-hmm. Okay? People would just resist something just because of the very nature of the person doing it. And that's what I want to talk about with you and the how of that as we work through that. How are you marrying that as you work through that? Successes that you've had in your prior industries of what you're doing through, because you're obviously they put you at the helm of GMR, not because you gave a good sales speech at a JP Chase Morgan piece, but because you have a history and a resume and a CV that gave them confidence that you could do that. I'm very interested in this. I'm off script right now, but I'd like to see if you would kind of allude and talk a little bit about that. I think would be helpful, Nick.
Yeah, look, I'm very open about this. One, and I think I've heard some of your other material. You talk about grace and whatever, and a long time ago, a good friend, former colleague, good friend of mine, at the time I didn't know it was a compliment, but he described me with having sort of this assertive humility is what he used. I was a little puzzled by the term, and I got to tell you, Asbel, and I say this sincerely, like people reach out to me, even like for this podcast, I'm still humbled by the fact that people think my opinion matters. Like I sit here going, because I tend to look at things, I have to break things down into simple blocks. I sort of have my 3-bucket analogy to everything. So as I came into the business after I made my big speech about, this is healthcare and I'm going to join the company to prove it's healthcare. Well, and this is all public. We were very highly leveraged. And like a lot of organizations, we started chasing a lot of top line and doing a bunch of things. So one of the first things we did was, and everybody kind of knew it. You knew it, but so we did 3 significant divestitures, and I say this very publicly as well. They weren't good or bad businesses. They weren't the right businesses for us. We were not built or wired that way, nor were our people. And the irony of it is as we started getting out of these things, our own field employees went, they finally understood. They knew it. They're like, why am I doing this? I love Mima, but I don't want to take her to her dialysis appointment. I'm not built for that. So as we started doing that, all of a sudden we started noting the metrics were changing. Margins were getting better, solider, performance was getting better, engagement was getting better. And you stood back a little bit in retrospect, said, sort of why? And it was pretty simple. We got rid of a lot of noise. We got a little bit more disciplined and focused on certain areas, and you started seeing that. And now, back on the successes we've had on bringing more payers in network, the successes we've had, on the hill, small wins, are why? Because we've been able to point to that focus, that discipline, and put things in front of people. Whenever I meet with lawmakers, my sort of proverbial little trap question for them is, I say, we consider ourselves as part of the safety net, like an essential service. And to a fault, they'll all go, well, of course you are. Well, I go, good. Now let's talk about legislation that supports that, because we're not recognized as that. So I think as we can continue, and it's got to be more than me as the, this has got to be back to the alliances and everybody getting on the same page. I think you're going to continue and see more of that recognition. Now, the onus is still on us to be good actors, deliver, have that discipline, share that information, you're going to get there. And interestingly enough, I've been a fix and build guy most of my career. That's been my playbook. It's distill it down to the things that you can get your arms around. And by the way, I often joke about the 3. You start getting beyond 3 things you're tackling, you're not going to do them well. Resolve them, get on to the next thing. Like we actually called our first 3 boulders because I said if we don't solve them, they're going to crush us. And fortunately, we got around that corner. Now there's still, especially in this regulatory environment, it's whack-a-mole, right? You've got to be nimble enough to navigate this space. But if you have confidence, and if you truly, this is going to sound really naive, but I live by this. We all say the patient, right? The patient. Well, if you actually do make the patient the North Star, everything else will follow. It really will. It may not always be obvious, but it'll follow. And I've listened to a couple of your episodes, and if you guide them to the right place and you get that trust, we can take care of people. And the irony is then someone says, well, someone loses. Not really, because if you do look at the waste in the system and the inefficiencies, you can replace that, get better access. I'm on the board of an advocacy group in DC, and one of the things I love about it is we're nonpartisan, bipartisan, and our one mission is that every American get access to quality, affordable health care. That's it. That's the tagline. And when you stay focused on that and you kind of stay away from the noise and you focus on those simple things, those are the blocks that you get to build on. But it does take patience. It takes some confidence. It takes a whole lot of trust to get there. And so I don't know if that answers your question.
Sure
probably
did.
went off a little
and
bit.
I'm going to here's all I'm going to say, because we're going to wrap up here. I got a little ding to remind me that because I could sit here and talk to you for a while. We'll have to do this again. Is a podcast that I just had with Dr. McCoy, who said, we were having this conversation, that the introduction of AI has given power back to the patient. That they're coming in. He's a doctor. He was a dermatologist. He does a lot of stuff with cancers and things like that. And he says now they will go through, they'll research ChatGPT, Claude, Perplexity, whatever it is. They've almost diagnosed themselves and come back to the doctor, and the doctor's having to say sometimes it's wrong. Now they can use AI. So literally the patients now got control where they used to not. It used to be, we don't really know. We don't know what price it's going to be. We don't know what's going to cost. That is all going to go away here in the next, I think I would almost bet dollars for donuts in the next 12 to 18 months, we are going to see a radical transfer. And I don't think the healthcare provider community is ready for it, about what's to come. And we talk about that podcast. So you should go and listen. If you have not listened to Dan McCoy's, there is a section in there where we talk about it. And they've actually got, his company actually, as an AI company, has actually got information relative to that. Mm-hmm. That's very interesting. He writes a lot of Substack. So it was just a very interesting conversation. And that was echoed even in my Scott Becker podcast and what you guys are doing. So I think the healthcare community needs to get ready for it as we work through. I'm going to ask you one last question. And we kind of went off on a little bit, but I want to ask one last question related to, if you look over the next, I don't even want to say 5 to 10 years, the next year to 3 years, from your perspective, and we talked a little bit about that, if we didn't have any regulatory burden, if we didn't have to worry about some of the stuff that we generally have to put up with in healthcare, of getting what I always say, great policy becomes good policy because politics gets involved, what would that be? What are you most optimistic about with all your conversations about where we're going to head in EMS?
We often quote Nurse Nav as our tip of the spear, and that's our label for it, but the other framing for it is, the way I frame it is, it's population health. And again, I care less about whether you wrap that under a value-based kind, whatever it is. And in our narratives, it's usually public health, but population health. So you think about what we do. And today, in the communities that we're in, we represent probably about 20 million covered lives in America. There's a potential to increase that to 100 million lives in the next 5-year window when you think about that. Why is that important? If you believe, like we do, and I'm passionate about this, that 20 to 25% of those calls coming in should be navigated somewhere else to get them more appropriate care. What's interesting is when I ran the value-based company, one of the constraints of those is you have to go to the payers and they have to attribute lives to you. And then you got to build density. Well, the beauty of the 911 system for us, not just as an organization, as EMS is, everybody's going to dial 911 when they have a perceived medical emergency. And we have the opportunity to grab them. And so many people have tried these different call numbers, nurse lines, whatever. We know it doesn't work. So as opposed to approaching it that way, let them call. They have a need. But now let's get them to the right places. And I know there's like the taboo terms of, people want like ED diversion and all of those. It's not even about that. Change the narrative. This is about getting people to the right site of care, navigating them, holding their hands, closing the loop with them, getting back to your communication piece. So what am I most optimistic about? We see that flywheel continue to build. It's helping us as an organization in the dialogue. We see sort of the requirements changing and evolving towards that. There are people mimicking it. Great. Like as big as we are, we're not going to cover everybody. I'm being sincere when I say we want to raise the tide. I think the more we can get people on board in developing these models and scrutinize our models and push back on us, and like you said, we don't agree on everything, that's how we're going to make it better. If we can get there, and I am seeing it, I saw it through the Alliance, I see it through the narratives, doesn't mean there wasn't some tension, it doesn't mean we took a couple of steps back, but ultimately, you look at the rescue packet, we put it out there, and we did it with a group of people. So I think I'm seeing that, and from the perspective of, it's funny because I'm still I consider myself still somewhat of an outsider. Like you said, the majority of people I've interfaced with in this industry have been in here for decades, which sometimes is good because you come in with a different perspective and you get to ask the dumb questions and go, really? Is that, and so that I am feeling optimistic and I see it. And where I really see it, and I'll close on this, is we've gotten bipartisan, bicameral support on this Medicare bill. Like, think about that. We didn't have to push anybody. Even when we did the VA issue, I mean, we had a whole bunch of people signed up for this, which tells me we've at least achieved they understand the importance of having a thriving, healthy EMS system in their communities.
Well, thank you, Nick, for showing up. I appreciate it. Spending the time and having a dialogue in your perspective. It's refreshing to hear from the value perspective side of it. And those that are listening today, you may not agree with some of the stuff he said. Don't focus so much on that. Focus on the stuff that mainly you can agree on. And that is how we're going to move EMS forward. That's how we're going to move healthcare forward. And so let's continue to have these dialogues. And Nick, I appreciate you coming in on the Leadership Lab and having a conversation. I don't want this to be the last, though, because I didn't get to some of my questions, but we don't want this thing to be 3 hours long. So I appreciate you joining us today.
Thanks for having me. Thanks for coming in Dallas.
Love it. Thank you.